Okay, great. Hopefully everyone can see this first slide, okay. But yeah, please let me know in the chat if you can't see anything or having any trouble hearing. Okay. So yeah, thank you so much everyone for joining this session today. So this is an event on personalised care in secondary care in London. So it will be focusing on specifically personalised care role support for secondary care patients across London. So the aim of this session today is to really showcase where personalised care roles are being used to tackle health inequalities in London and are also having a huge impact on patient care and outcomes. It's also aiming to come together as leaders across London to really explore how we can better collaborate to further this agenda. So you think... Could everyone just stay on mute if possible? Thank you. And then we're also hoping to further explore as well what we hope to achieve within this space, within secondary care and personalised care. So we will be welcoming Melissa Heitman, a respiratory consultant at UCLH Hospital, to share a bit more about why we should prioritise personalised care in secondary care. We also have an amazing group of speakers who will be presenting specific projects embedding personalised care roles in secondary care in London, specifically supporting cardiac patients, chronic pain patients, and also patients in emergency and discharge departments as well. And then we'll also be welcoming Jane Clegg, Regional Chief Nurse and SRO for Personalisation at NHS England London, to share our 2025 ambition for London. And then we'll also finish with a 25-minute panel discussion to have a broad discussion around personalised care in secondary care, but it will also be an opportunity for you to ask further questions to the project presenters as well. So just briefly before we start, a bit of housekeeping. So we are recording the session today, so if you'd prefer to keep your cameras off during the recording and unless you're speaking, then that's absolutely fine, but up to you. Please do keep yourselves on mute unless you're speaking as well. And if you would like to speak, please just raise your hand or pop any questions in the chat. We'll be checking that throughout the session today. We will be using Slido at a couple points during the meeting today. So Beth, my colleague, has just popped that in the chat. So you can access that via the link there or by using the QR code.
You want codes? I don't know what you're saying.
No, I'm just
sorry.
It's a meeting. I'm not parting.
Please, could you go on mute? Sorry. Whoever that is. Thank you. Perfect. Okay, so I'll just hand over to Mel, who will be sharing a bit more about why we should prioritise personalised care in secondary care, the impact that these personalised care roles can have on tackling key challenges across the system, and also we'll be sharing a bit more practical examples and tips from a real life long COVID clinic example using social prescribing. Thanks, Mel.
Thanks, Molly. It's lovely to be here with you all talking about this really important opportunity for us to support our patients more effectively. My background is as an integrated respiratory consultant, but since 2020, I've led a post-COVID service at UCLH, and I work with the National Long COVID programme at NHSE. And over the last 3 years in caring for people with long COVID, you know, the crucial benefits of bringing broader access to a sort of broader offer of support to better manage a person's wider well-being has really come to light for me. So it's great to see this work taking shape in London and across the country now. We thought on this slide we should start with a reminder of what we mean by a personalised care model. And our focus today within this model is how at secondary care touchpoints we could broaden patient access to personalised care roles to support this agenda. So if we just remind ourselves about this universal personalised care model, this is really a concept where we're thinking about how health and care will be organised in a different way, with a new relationship between patients and healthcare professionals, where patients have a stronger voice, a better, fuller understanding of their condition and of the choices available to them to manage their condition, and where they're better linked to other sources of support in their community. And if you look in the lovely circles underneath, these are the different elements of that model. So starting in the light blue, thinking about shared decision making. I think many of us have accessed some excellent training in growing that skill set as clinicians in supporting patients in those kind of conversations. Thinking about enabling choice, having access to social prescribing, which is that process by which you can link people up to broader support in the community. Growing knowledge, skills and self-confidence through health coaching and supported self-management. You know, there's an ever-growing breadth of offer in terms of how you can support people's understanding about their condition now. And then thinking about developing a person-specific plan, and then thinking about financial elements, so managing their budgets and accessing useful options such as personal health budgets and integrated personal budgets. So those are some of the 6 components, and what we hope through access to that model is that we could achieve some really special benefits, aiming to improve population health, ensure care is better tailored to patients and communities, relieving NHS pressure through bringing in other avenues of support, addressing health inequalities, and even important goals such as reducing excess mortality and emergency admissions. So a lot to potentially gain if we feel, if we do this right, we feel the evidence supports this. So on the next slide, one of the key roles of ensuring better access to personalised care is in supporting people to manage the wider determinants of health. And these are those aspects about a person's life which have a huge impact on their health, either through increasing their risk of long-term conditions or impacting their ability to manage them. And here we're thinking about their educational opportunities, their living conditions or their employment. And we know that these wider determinants are estimated to account for approximately 80% of a person's health outcomes. So personalised care approaches, if we do that well, could be an important resource to try and compensate for those wider elements or overcome them to some extent. And then if we look at the next slide, we don't want to start the new year on a downer, but this is a moment when the need to address these wider determinants of health is greater than ever. NHS pressures are very significant due to backlogs from the pandemic and now industrial action, the cost of living crisis, and of course our ageing population. So widening access to personalised care interventions at more contact points with the NHS could extend their reach and bring extra benefits. So on the next slide, if we think about why should this be a secondary care priority, why are we looking to focus this there? And I think, you know, there's a number of compelling arguments. First of all, some of our most vulnerable and complex patients have large amounts of contact with secondary care, either through our emergency services, through admissions or through outpatient contacts. So we have a captive audience in a sense in hospital. I've learned as a respiratory clinician that admission is a very important moment to try and support someone to quit smoking. And if we could also, during those days where we have a lot of contact with a person, try to bring them access to addressing other important elements of their health and well-being, then that seems a no-brainer, doesn't it? And this could bring benefits for secondary care. If we did this well, we would expect to see reduced admission rates, length of stay, improved patient flow in our acute hospitals. Increasingly, I think we're taking on more responsibility in secondary care in driving early diagnosis in our local populations of long-term conditions. There's a good example of this at the moment in the spirometry programme, where across London a lot of secondary care clinicians are involved in trying to improve the quality and consistency of provision of spirometry within primary care, and we're having to work across the whole system to make sure that people get an accurate diagnosis of asthma and COPD. And I think we want to see this as part of our responsibility within secondary care and our contribution to addressing population health. And of course, in secondary care, we are looking after many people with long-term conditions. Some of those fall within the conventional cardiovascular, respiratory disease, diabetes pot, but there are many, many other long-term conditions which are managed through secondary care, particularly outpatient services. And if we can focus in those pathways on doing everything we can to support the self-management of a person and their long-term condition, then that could bring many benefits. So on the next slide, and this is my my last one, I looked back over the last 3 years just to think about how we'd made progress in bringing personalised care into our long COVID clinic, and what were the useful steps along the way. And I think the first thing was that our MDT team clocked quite early on how important this was for our patients, and we kind of aligned our thinking as a department and as a pathway that this was something that we wanted to do well. We also had the opportunity to work as an integrated care system and build relationships with all the providers working in the pathway, and our ICB supported us to make connections with the voluntary sector, which proved to be extremely useful. Long COVID, obviously, as a new condition, meant that we needed to learn as much about it as quickly as possible. And we developed tools to help us understand our patients' experience of their illness better. And within that, we were able to capture learning about what the impact of their condition was on their wider life and how their wider life affected their ability to manage their illness. And it made me realise that I probably wasn't asking enough questions like that about patients who I saw in other clinics in my respiratory job. So understanding your patient cohort, I think, is a key step. Sometimes the partner organisations you want to work with might be on your doorstep, and sometimes they might be further afield and national groups. And for example, in long COVID, we've had amazing collaborations with the English National Opera, with Scottish Ballet, who've all run free support programmes for people with long COVID. And then we got to work on our doorstep with Voluntary Action Camden, who linked us up with the voluntary sector in NCL. And we got to learn about personalised health budgets, and a very large number of our patients with long COVID are now able to access these, and I've seen the benefit of that really come true. It's occurred to me over the last 3 years that in some ways, when you have a fancy complex treatment to deliver to your patients, your bandwidth for thinking about the other elements of their health is less. In long COVID, we haven't had a medicine to focus on, and therefore I think we've done better at thinking about the broader aspects of their health and giving them access to personalised care and personalised care roles. But in my other clinics, I might be using immune suppression or complicated drugs, which take up a lot of my conversation time. And in a way, we need to think harder in those contexts about how we don't miss a trick on the other things that are important to that person. And then I think for your service, you need to think about what's the right model for accessing personalised care for your patients. Could it be that you'd benefit from having a dedicated social prescriber in the team? That's something that we found extremely helpful. You need to get the geography right there and work out where your patients are coming from and who that social prescriber can refer them on to. We found training for the whole team in personalised care approach is extremely helpful, and it's actually quite new content for a lot of secondary care clinicians. I think primary care have been doing this for a long time, so that was really valuable. I've mentioned about forming the partnerships and building relationships, because what's been most effective for us is where we can implement something and then develop and improve it together. And then increasingly we've become aware of the integrated neighbourhood teams developing in our ICS, and we're keen that secondary care clinicians can play a rich part in those teams, so that they know where they are and how they can be useful to them. And I think that's something that's going to be a really interesting area for development. And then, of course, you want to monitor your progress. And in long COVID, we've been very focused on monitoring outcomes because it's a new disease to learn about. But this is something that we should be doing broadly. And that will give you information about whether there's equity in access to the support, the enhanced support that you're able to offer, and equity in outcomes as well. So really exciting space, a really rewarding space to work in, and I'm looking forward very much to hearing about everyone else's experiences. So thank you very much. I'll pass back to you, Molly.
Thanks, Mel. Yeah, really great to hear about, I guess, key priorities in secondary care and how personalised care interventions can really help align to those as well as also those practical tips, which I think are really useful from a real life example in the long COVID clinic. So thank you. Okay, so I just have a few slides kind of sharing more about what we've been doing at regional level to support this agenda and some of the kind of learnings and findings that we've found through our mapping work as well. But I'll whiz through these so that we have time to hear from each of the project presenters. So improving access to personalised care across secondary care in London is a key regional priority and area of work. And as part of this, we have been aiming to share and spread innovative and impactful examples, improving access to holistic support in secondary care. We've also been aiming to support sustainable and integrated pathways that support that continuity of care for patients as well. In terms of what we've been doing so far, we've been mapping where social prescribing and personalised care are supporting secondary care patients, and I'll share more about the findings from that work in these slides. We've also been developing key case studies on our website for innovative and exciting pilot projects, and we've just shared the link to that in the chat, so you can go look at that as well. We've been providing direct support and resource to pilot projects in development, in particular through planning, co-production and evaluation. And we've also set up a pan-London community of practice for anyone interested or involved in expanding personalised care roles in secondary care. Then going forward, we're hoping to support the development of resources that support the system to embed and expand personalised care roles in secondary care, to continue supporting integrated neighbourhood teams and partnership working, and also supporting the development of a strategy to expand personalised care roles in secondary care. So, as I said, we've developed a pan-London community of practice or network to champion and support the development of integrated and sustainable approaches to improve access to personalised care in secondary care across London. So you can see more there about who's involved, the activities, what we've done so far, and what's next, as well as how to get involved. Just to say, we'll be sharing all of these slides afterwards as well, so you can read more on those there. But I did just want to share a bit more about some of the learnings that we've mapped so far. So personalised care interventions in secondary care, there's not one uniform model. There's loads of different cohorts that can be supported, and loads of different referral pathways and service models, as you can see there. Also, due to there being a lack of funding and policy for personalised care roles in secondary care, There's often discrepancy across the system in terms of job titles, descriptions and responsibilities. For example, you can have community connector roles, care navigators, etc., which are often doing similar functions to social prescribers. Also, we know that due to issues with capacity and lack of established pathways for referral, facilitating that referral from secondary care into the community can also be quite challenging. As part of one of the community of practice sessions, we also collectively brainstormed what we were aware of in terms of personalised care work across secondary care in London. And this helped us to map out different specialisms and cohorts that are commonly supported, different personalised care service models, and also referral pathways. So I won't go into detail about that, but you can read that through when we share the slides. We also know that it's really important to thoroughly evaluate personalised care interventions in secondary care in order to really demonstrate the impact and the value to funders to secure future investment, to ensure that pilot projects can be sustained and scaled beyond 1 or 2 years, and also more widely to demonstrate why personalised care should be considered business as usual and embedded across all health and care services. So you can see there as well some more examples of evaluation methods and funding models that have been used in different secondary care personalisation services. So London is leading the way in embedding personalised care support in secondary care. So I've highlighted a few examples here. For example, in North West London, 2 pilot projects used community champions and wellbeing coaches to provide community-based alternatives to high-intensity users of emergency services. And actually, one of those pilot projects saw a 41% reduction in clinical contacts. In Barts Health Trust, a social prescribing link worker has been embedded in the Royal London Renal Department to support children and young people with long-term conditions. And also Niche are funding a 5-year programme of research to embed and evaluate a health coaching and social prescribing intervention for people living with HIV. We also know that many of these projects are already achieving huge impacts. So as you can see, a high intensity user service using care coordinators in North Middlesex University Hospital has led to a 30% reduction rate in emergency department attendances. In South West London, a Macmillan Community Link Worker service has led to increases in life satisfaction and well-being and decreases in anxiety. And finally, a project in North West London as well, which you'll hear more about from the project leads in this session today, but supporting patients with chronic pain led to a reduction in referrals to secondary care through providing more appropriate support in primary care and in the community. But before I hand over to our project leads to share more about each of their projects, I just wanted to introduce Slido again. So my colleague Beth will just pop the link in the chat. Thanks, Beth. And yeah, there's some questions in there because we'd really like to hear from you around what you think the most important factors are to consider when introducing personalised care roles in secondary care, and also what the biggest benefits could be as well. But I'll just leave that open for everyone, and then I'll bring in Tara to present on her project. Hi Tara, would you like me to share the screen or do you want to share?
Hi Molly, I think I'm in the process of sharing. Can you see that?
Yeah, perfect, thank you.
Hello everybody, and thank you so much Molly and to the whole team at TPHC for first of all their support throughout the building of this project, and also planning this webinar, which is really wonderful to see all the different projects in London come together. I'm going to talk to you very specifically about our project, which admittedly is in its infancy, dealing with social welfare and cardiovascular disease. And I think from our point of view, there are two major hurdles to implementing social prescribing in a secondary care setting. The first is awareness about social welfare and the impact on cardiovascular risk. And then the second is integrating into that network that's already so rich and beautifully robust throughout primary care, where secondary care really didn't have a role before. And so I think to address the first one, it's really clear there's a ton of pretty gold standard evidence that shows that the risk of being socially deprived is equivalent almost to the risk of high alcohol or hypertension in terms of the impact on cardiovascular mortality. It is a no-brainer that us at the Heart Hospital should be dealing with social welfare and social deprivation in our regular and just routine care for patients. But it became pretty apparent to me when I started integrating this question into my practice. And I'm a vascular surgeon. When I deal with aneurysm disease, which is the bulk of my practice, I occasionally ask patients, do you have difficulty making ends meet at the end of the month? And I have been very surprised at the impact that the answer has on people's decision-making for whether or not they want surgery and how compliant they are with their care. In fact, with this specific patient who had a symptomatic aneurysm that needed treatment, I connected him with a social prescriber when he admitted to having financial issues. And at the end of the surgery, everything went really well. And he really credited the social prescriber for saving his life because it was the social issues that were causing the biggest burden in his day-to-day stress and well-being. We decided to kind of start on this journey doing a fact-finding mission. So the first thing we did was deploy a question across anyone who engaged with our app and ask them, do you have difficulty making ends meet? And what we saw here is that there was a significant portion of patients with aortic or cardiovascular disease who really had difficulty at the end of the month. And we thought this was a big enough fraction of our population that we should explore it further. And so we brought the same question to the outpatient cardiology clinic in Newham. And using the digital questionnaire, we actually this time developed a screening tool where we asked a number of different questions of the patients that were coming to outpatient clinic. And we screened about 150 people in the process of this project last autumn. And what we found, not surprisingly, that digital engagement was quite low amongst this group. And but for those who did complete the questionnaire, there were quite a bit of concerns, and specifically financial deprivation became really apparent. And the lessons we learned from this was that there definitely is something needed and something we can provide in this space, but it needs to be done with a human being. And so we worked with public health, and one of the first things we did was bring a health and wellbeing coach into the renal disease department. And the public health department at Barts is absolutely brilliant. And what we found, and Maisha has been in post since August, she was able to engage with every new dialysis starter, and they were completing the questionnaire 80% of the time and flagging a concern quite frequently. And so this says to us that having a human being involved is really important, which is where we are now with the Barts Heart Pathway. What we've decided to do is screen everyone who has an acute MI, and that's 5,000 heart interventions done a year at Barts, using our digital questionnaire. But for those who can't engage with the digital questionnaire, we've embedded a social prescriber in the pathway. And our ACPs and social prescriber are screening the patients. And if they flag for concern, then they're actually getting extra social prescription, either from the social prescriber we've brought on board or by engaging with the community and dealing with their local social prescribers. Our process map looks something like this. After a person has an MI, they get screened. If they don't show up, then they're immediately flagged as a concern, and they're called by the social prescriber. And for those who are screened and flagged as a concern and who want help, then they're also flagged as a social prescriber. What we found is that this pathway is really fitting beautifully with the psychology support that we already provide along the acute MI pathway, as well as the safeguarding support. It was actually that missing piece of social welfare that was needed in this population. And what's interesting is that it's integrating into a much larger network. What we're finding is that a lot of the things that cause cardiovascular disease are also the things that are leading people to screen positive. And certainly when we push them back out into the community after their heart attack, what we're finding is that a lot of the things that cause the disease are the same things that are preventing them from being well. And so it stands to reason that we have engaged across all of Northeast London in order to integrate this pathway, learn from the brilliant teaching that the primary care network already has, and hopefully bring some of that learning to what we're doing. There is no question we are building this plane in flight. It sometimes feels like we are constantly changing what we're doing, but what our hope is that by being a reasonably nimble pathway, we can actually express and deal with the concerns that patients bring up. We've changed our tool again so that instead of asking all those questions, which became really time consuming, we're just asking one question, but really leaving it open for the patients. And the outcomes that we're looking to understand is the burden of the disease, the classification systems that we can use to understand the burden of disease, the needs in the community, and then hopefully with social provider intervention, what we're hoping is that we can also show that there are some decrease in resource utilization. And you can see that this project is very early on. We've just brought the social prescriber in, Remy, who's brilliant, in 2023 in the beginning of November, and we've just started to screen patients. And our team brilliantly has been working over Christmas and has screened almost 100 patients so far. And what we found is that almost a third of patients who are screened through this pathway are having difficulty making ends meet at the end of the month. So there is no question that this patient population is in dire need coming through the heart attack pathway, and hopefully will be something that we can help address. Hopefully by this time next year, I'll be able to tell you the huge, beautiful impact that our wonderful ACPs and that Remy has made on the care in the patients in the pathway. The goal at Bart's really is to change the current social prescribing ecosystem in Northeast London so that we can integrate and really be responsible team members in taking care of our patients and their social welfare needs. And it's thanks to the beautiful, wonderful people at TPHC and everyone across Northeast London that we've been able to make it this far. And I thank you for the time.
Thanks, Tara. That was brilliant. I mean, I think it was amazing to hear more about, well, really powerful, first of all, to hear more about the link between social deprivation and cardiovascular disease risk, but also great to hear about how personalised care roles can really help to link up secondary care, primary care in the community as well. So thank you. Does anyone have any burning questions? We will have more time for questions for the presenters in the panel discussion, but we might have time for one just now, if anyone. Yeah, Rebecca.
Thanks for that. That's a really interesting perspective. I'm my Bromley lead in South East London for personalised care, and part of our mapping process we're doing at the moment is looking at how everything in personalised care really links up, and communication between the different services is key. So I'd be interested to know how the work that's being done in the clinics in that way, how is that being communicated back to primary care?
That is a brilliant question, and one of the things that we struggle with the most. We're using the East London patient care, forgive me, I'm blanking on the name, but the patient record, excuse me, the East London patient record. Much of the correspondence we have for GPs goes into that record. And so by using our common pathways for corresponding with GPs, we're able to upload it into their system so they can see. What we don't have is a case management tool that can allow us to collect coding and really understand social prescribing the same way that the primary care network does. However, we've built a very, very basic database collecting those same same codes. And what we're hoping is that when we have the evidence that this has been effective, the commissioning or the funding for this will come at a bit of a higher level, so that social prescribers across the entire network will be using the same tools. But that's a bit of hope right now.
Great. Thanks, Rebecca. Thanks, Tara. Okay, so I'll just share my screen again and then hand over to Selina and Calwan, who present about the North West London chronic pain pilot using social prescribing.
Hi everyone, can you hear me okay?
Yeah, we can.
Yeah, so hi, thanks very much for inviting us to talk today. I'm Selina Stellman, I'm a GP working in North West London and in Surrey, and my colleague Calwan Sahota works in the personalised care team, and she's going to be, we're going to be sort of co-presenting this today. And this is really a project that we've been doing in North West London over the last sort of 2-3 years, which is around introducing a personalised care approach to supporting people with chronic and persistent pain. Slightly different angle from some of the other presentations, and this project was really around actually trying to reframe some of these people who are being at the moment referred into secondary care, seeing whether we can support them in primary care, but while still maintaining a link between primary care and secondary care, and using really all the members of the healthcare team across the board to support these people when and where they need it in a personalised care approach. So if we go on to just the first slide. So people with chronic pain. So these patients are often very complex. They've got complex medical, physical, psychosocial needs, and this is often on a background of people who've had significant emotional or childhood trauma, making them really quite challenging for them to navigate the healthcare system with all of their complex needs. They're frequently high users of primary, secondary and out of hours and unscheduled emergency services. But in spite of this, they still report having very poor experiences of care. So they're often under multiple different specialists. In primary care, they get these really short GP appointments and a lack of continuity, which doesn't help with them being under lots of specialists. There's often a lack of GP knowledge and confidence in managing chronic pain. And all of this really results to them being often inappropriately managed in the system. So they're over-investigated, they're given unnecessary analgesia prescriptions which don't work and give side effects. And they're often inappropriately and unnecessarily referred into secondary care, which is just not a helpful use of anyone's time and not also necessarily beneficial for these patients themselves. Next slide, please. So with this in mind, we designed a kind of pilot model. The real aims of it, of this project, were to sustainably improve health and well-being of people with chronic pain. And that was by proactively trying to help them to increase their knowledge, their skills and their confidence in self-management. We wanted to try and tackle some inequalities through supporting engagement with local communities, because we know that people with chronic pain are more likely to be socially deprived backgrounds, women, Black and ethnic minorities, refugees, asylum seekers. So we wanted to try and focus on that as well. And the approach that we wanted to do was really to offer a primary care based personalised care support planning approach, but that we would do this in conjunction with secondary care, so working as part of an MDT and getting support from the secondary care specialist as we need it. We wanted to really try and improve their health and encourage people to be able to self-manage, to understand their pain and really set them off so that they can improve their overall life and well-being in the way that matters to them. So we did this, came up with this pilot model, which we trialled in a large GP practice in North West London. We started in 2001. We've subsequently expanded the similar model. So we've now got 4 PCNs who are currently running something similar and another 2 that are about to start. And the model essentially is that the person is identified by a healthcare professional in primary care. This may be because they have complex chronic pain, they're a frequent attender, they're using services regularly, they've got really complex needs. And this person is invited to have a conversation about their pain with a clinician. At the pilot site, that was with a GP. In some of the newer sites, we're trying it with pharmacists, health coaches, and other allied health professionals. And this initial appointment is longer. It's about half an hour. And it's essentially to say to the patient, what do you want to talk about? Rather than us leaving the agenda, it's really true personalised care, saying, tell us about your pain, tell us about your journey, tell us about whatever you want to tell us about. And actually, through doing this, we're able to help talk to people about what they understand their pain is caused by, what they understand their diagnosis is, what do they think their needs are, rather than what do we think they are, and help them with some early goal setting. From this, sometimes the GP or whoever's delivering that initial appointment will be able to already signpost patients to appropriate resources and services, which might be in the community. We discuss complex patients in an MDT, which I'll come on to talk about in a second. And there may be other services and referrals that already become apparent that the patient might benefit from, such as a pharmacist or a physio or a health coach. The patients have a follow-up appointment with that same clinician a couple of months later, which is around reviewing their goals, their progress, and what was the outcome from that MDT. And alongside this, patients continue to access services in healthcare as they normally would. So this is not designed to be a pain clinic that treats everything. This is just an opportunity for patients to have a really personalised care, holistic approach to their care, just to have a look at their chronic pain as one of their major problems they're dealing with. On to the next slide, please, Molly. So the MDT, these run every 4 to 6 weeks for an hour on Teams. And they're essentially to offer a space for the clinicians involved in this patient's care to explore the diagnosis. So if there's a bit of diagnostic uncertainty, for the GP to ask, discuss the different support options, share resources, and discuss potential referrals. So from the primary care team, we had the GP, we had social prescribers, health coaches, and a primary care pharmacist. And from secondary care, we had a consultant rheumatologist who specialised in pain, a physiotherapist, and a specialist health psychologist with an interest in long-term conditions. And part of this, as I said, was discussing these complex cases. Is this patient suitable for a health coach referral? Do we think they've got fibromyalgia, or is there something more complex going on? Do they need referral into the hospital, or could we avoid that referral? And it also gave the opportunity to think about doing joint consultation. So we had a few patients where, following the MDT, the patient would have an appointment with me as the GP, and on Teams, I'd have the consultant rheumatologist. So we could have a really nice joint consultation all together. And the MDTs allow for ad hoc support to be built, and building relationships between the team members as well. What's the next slide, please? So we did some evaluation of the pilot project in terms of benefits to the patients. We measured their MSKHQ score, which is a measure of musculoskeletal and non-musculoskeletal symptoms and well-being, and did find a substantial improvement in this. We found improved patient activation measure scores, which is well validated, showing evidence of improvements of understanding and confidence in managing their symptoms. The management was more consistent with NICE guidance, so in terms of chronic pain guidance, we're providing a personalised care approach, a patient-centred holistic approach, and prescribing, trying to get that back into consistent with the guidance. And patients really reported having a major benefit from having these ARS roles, so the social prescribers, the health coaches, and these other roles that they didn't necessarily normally get to see to help support them with their pain. And there's just a few comments there from patients from the survey that we did with people who've been through the pathway, about really appreciating feeling validated, having time to actually go through their discussions, and having this kind of follow up where they could kind of build on from what had been going on. In terms of the clinicians and the team, the clinicians actually delivering the appointment found there was also about skilling, improved job satisfaction and variety, which I think in the current climate is extremely important. And actually in the GP team, there was reported to be greater awareness of diagnosis of chronic pain, which is something that we know from a survey we did before the pilot, that actually GPs often lack that confidence in managing it. Crucially, and I think particularly relevant for this, thinking about primary and secondary care, there was this really great improvement in team relationships and MDT working. And this didn't just extend to the chronic pain patients, but people beyond that. So actually it meant that the secondary care clinicians suddenly understood what health coaches could do in primary care. And as GPs, I understood actually what a specialist psychologist could do. So we all understood each other's roles better, and were able to really make sure that we utilise the skills of different members of the teams. And actually, I think from that, we all learned a lot clinically and non-clinically. And it led to things like reduced referrals, reduced inappropriate investigations, and more appropriate prescribing. Finally, in terms of thinking about the system, It's not all about finances, but it's important. The improvement that we saw in the patient activation measure score, that's a really well-validated measure and has been shown to improve cost savings and outcomes. The improvement that we saw in the pilot, if that was extrapolated to across the board, we would estimate that we'd save about 3 GP appointments per patient per year and have quite a substantial demand savings per patient per year for primary and secondary care. Anecdotally, we noticed reduced use of GP appointments, any attendances and unplanned admissions, and we saved referrals, partly because we were able to use that MDT, partly because we could do dual consults, partly through upskilling of the team, actually, that we just understood that we didn't need to refer these patients in secondary care and they could be held in the community. There was increased use of the MDTs and the ARS roles, and as I mentioned before, improved prescribing, which was more in line with NICE guidelines, and particularly looking at opioid use as well. With the next slide. I think Calwan was going to, if you're there, Calwan was going to just talk about one of our stories, just very briefly, about one of the patients who we had go through the pathway.
Thank you. So in terms of the pilot, as Selena's just outlined, so this was very much an approach that the health and wellbeing coach focused on, and it worked with an individual that had quite a lot of consistent pain over a number of years and also underlying mental health issues, and they were quite isolated. So they were able to use this particular approach in order to make quite substantial changes for this individual. So they went from actually never leaving their house to actually ending up kayaking and using social interactions with different people. So I think what it shows is the fact that those small consistent changes and behavioural changes and using a number of techniques can actually have a really positive impact for that individual patient that's having long-term pain issues. And as the outcomes clearly show, that reduce the number of hospital appointments, but also GP appointments as well, and shifted their sort of like care from unplanned to planned, and improved their overall health and well-being, as well as improving sort of like monetary and economic efficiencies as well. I'm really conscious of time, so the next few slides just about that highlight how we embed and how do we make that structural and cultural behavioural change within staff and within the system as well. So in order to embed some of that training and learning that we've been happening, we've set up a really reflective practice that happens. Myself and Selena host that, and some of the key themes that are coming up around that is around welfare benefit advice, access to physical activities, around techniques for pain management, but it enables people to have that safe, secure sort of like environment where they can learn about key themes that are happening. And also we offer health coaching for pain as well, quite a specific technique. And in terms of our next slide, so we've actually also set up a community of practice as well, which is looking at how do we actually change and bring people together to change the way we work with people that are affected and impacted by pain within the system. And that's largely for patients, our local residents, but also for our health professionals as well. And we're more than happy to share our lovely newsletter that we produced after our second session for our community of practice and share some of that key learning. We have 2 further community of practices to happen in January and March, and then we'll make a decision as a collective around what does that actually mean and what can we do in the future. So thank you for listening, and we've got some key sort of like information in terms of our purposes and aims, and I'm sure the panel will host a number of questions. Thank you.
Great, thanks Calwan, thanks Selena. It was really, really great to hear about how different roles are working so well together in the MDT, and also the extensive impacts for not only the patients but also the clinical team and the wider system as well. So thank you so much for that. I've just seen a question in the chat, but if it's okay, just conscious of time, we'll keep that and we'll keep it for the panel discussion, and I'll just hand over to Deb and Steve to share their project as well. Slide.
Hello. Hi. Well, thank you, everybody. Thank you for inviting Steve and I to deliver and talk to you about our work at the QE Hospital. I've just put a few things together on the slide. I'm the head of health improvement at Charlton Athletic Community Trust. You can probably see the brand somewhere down there. Why am I working for a football club? Well, that's because we're a community voluntary sector organisation that works. Good. Community voluntary sector organisation that basically is commissioned by public health. We have a public health workforce here, and we have done since 2006, when the smoking ban first came out, and we trained up football coaches to be stop smoking advisors. And from that time, they've developed through a range of behaviour change support for the public and become a workforce for public health in many different areas, including a 2-year project where we did, I think it was 10,000 blood pressures. They've worked on a health check programme. It's all community voluntary sector. Currently, we're commissioned to deliver 2 key aspects of the infrastructure for social prescribing and personalised care roles in Greenwich. And that includes a call centre where we have social prescribers, we call Live Well Coaches, working, supporting people. And also we have about, I think it's something like 45 staff working in practices in Greenwich as all through the personalised care roles, including the social prescriber, health and wellbeing coaches and care coordinators. With that infrastructure, which is a gift, obviously, we have been asked by the QE Hospital through the board here to support with social prescribing in the hospital discharge team. So what we've done is we've used all of that infrastructure, all of those years of experience and all of those staff to come along and work with the discharge team, and with the aim of shaving off or making sure that people are discharged from hospital in a timely manner. And obviously the pressures on at the QE in a very difficult situation. Why did they think we would be able to help in that? Well, because of the very things that everyone's been talking about, that we've listened to, which are amazing work that everybody's been recounting. Because a lot of the things that keep people in hospital are the same things that send them in. Money, debt, benefit issues, not eating well, employment problems, people that are completely not linked to their community in any way. So they're socially isolated, housing issues, domestic abuse, all of those things are keeping people in hospital longer than they ought to be. The conditions that people are living in are the thing that we try to tackle. Yes, there are avenues and pathways to provide some of this support in hospital for the hospital discharge staff, but what we have been able to do is link community voluntary sector support and our support much quicker than you can do in normal circumstances. So if, for instance, people need furniture moved in a home and it's going to be a four-week turnaround, our team will get that done within a day or two. So at the moment, in the hospital discharge team, we've developed a fantastic relationship with the staff there, and we have a staff team that works in the hospital discharge team every day. They've received 192 referrals so far, and most of them come from the particular hospital discharge team, but the referrals are also received from teams throughout the hospital, social services, and also other local hospitals where Greenwich residents are in terms of step-down accommodation. We do things like temporary key safes, because we found that was a big problem. There is a pathway for key safes to be installed, but often it can't be done in the time needed to get someone home in time. So we work with the team in Royal Borough of Greenwich, whose job it is to put key safes in. They provide us with temporary key safes, which if Steve's here can correct me if I'm wrong, we can put in place in 20 minutes. Then we can wait. Sorry, Steve.
Yeah, that's correct. Yeah, they're just basically a large padlock. So as long as there's somewhere to put a padlock at the property, it takes as long as it takes us to get from the office to the property, which on average is about 20 minutes. So
that will shave off even days of someone's getting discharged from hospital. Thanks, Steve. And what will happen then is that the team that are meant to put the key safe in, can do that in their normal time period. They'll go along, put the permanent key safe in and give us the temporary one back. We do lots of furniture moves in the same vein, where it's going to take a week or two. We will go in and move the furniture so that occupational health can get their kit in there as soon as possible. Do you want to move on to the next slide for me? These are the pathways, really. You can see that most of the people here are, oops, what happened there? Pathway 1. This means that they're discharged with the support of medical equipment or, you know, the package that's required. And you can see that pathway 2 and 3 are 4%, 6%, and pathway 0, 22%. We're commissioned, luckily, very similar to everybody else, to support people with whatever's important to them. So we will get a referral from the hospital discharge team, which will be quite narrow in scope, which is this person needs some food, needs some furniture moved, and they need maybe a befriending referral. But when we speak to the patient, we see them up on the ward. We'll get the referral. Our team will then go up on the ward and speak to the patient. And we will ask them that question: how are you getting on with the cost of living? How's it affecting you? And they will tell us. That will all open doors to different kinds of support, all of that stuff that's going to help support somebody in the community and the wider determinants. So I remember a referral that I was dealing with where somebody was being discharged home, but actually was in a situation where there was cuckooing, which is where people have moved into the property because this person's vulnerable, acting as though they're family and friends, but in fact they are there taking all the resources, making the place into something that's not habitable anymore, and obviously oppressing and stressing out the patient. So once they tell us things like that, we are able to then marshal a different level of support in the community. With our programme, we have a multidisciplinary team that sits every Tuesday for cases such as that. So the referral will come in from hospital discharge. It will be about removing furniture. Once we look into it, it can't be done. The cuckooing situation needs dealing with, and it's quite complex and quite time consuming. So the multidisciplinary team on Tuesdays has housing, Oxley's mental health team. It has the welfare rights team on it, and also GPs, and we invite whoever's necessary, so it could be environmental health, to come on, dependent on patient need, to work through solutions, and it works really well. We're able to put orders in place, environmental health orders, and get people moved on, and get cases referred to the MASH team, and any place that's necessary to move the situation along in a positive manner. Next slide, please, Steve.
Sure, thanks, Deb. Just to flag, probably only about 2 minutes left.
Okay, no problem. Next slide. So, as I said, referrals come from all sorts of areas: Princess Royal Hospital, Langton Way, which is a care home step down, and our team will invariably support people with what really matters. And having the staff on site at the hospital discharge is really important. There's one more thing I wanted to explain. We have another piece of work in the urgent treatment centre. If you want to click through a couple of slides for me. Yeah, just another one more.
That's
So
it.
that's it. So we've also been piloting a social prescriber, or a team of social prescribers in the urgent treatment centre, and we did this for 8 weeks. In 8 weeks, we had 99 referrals. That's slightly different in that a lot of the work there is in supporting people that are not registered with a GP. So there's predominantly lots of GP registration and appointments, but there's also lots of housing needs, homeless people, getting them back into the housing market. Lots of people, we've got domestic violence, and people need support with that kind of thing, and getting people dressings and things like that. Lots of health and wellbeing support in general. So the projects are kind of both in pilot phase, really, but they've both worked so well at the moment. We haven't got any kind of outcome data other than what I'm showing you here, but I'm sure that if next time we'll be able to explain a little bit more about how both those projects are going. Thank you.
Amazing. Thanks, Deb. yeah, apologies that we had to kind of rush through that a little bit. Sorry for the lack of time, but it was really, really great to hear more about the project and the amazing work that you're doing and the great kind of partnerships and relationships you've built with the local community as well. So thank you so much for that.
Just one thing I'd want to say was in
Yeah.
terms of data, we've got all the staff that work in GP surgeries. That means that patient notes are written back into EMIS in primary care. So that makes it a lot easier to link what's happening in secondary care with that person. Sorry.
Thanks, Deb. No, that's really helpful. That's a really helpful point. Thank you. Okay, so we'll leave questions to the panel discussion, but I'll just hand over. Sorry, let me sort out what I'm sharing. And then I'll hand over to Jane Clegg, who is Regional Chief Nurse and SRO for Personalisation at NHS England London, who will be presenting. Oh, is that presenting the right slide? Yeah, who will be presenting the 2025 ambition for London. Thanks, Jane.
Thank you very much, Molly, and thank you, huge thanks to our presenters. It's amazing work that you're all doing, and I will be as quick as I can because I'm sure you've got lots of questions. I think with the quality of those presentations and just the kind of absolute, why are we not doing this? I think our ambition in London is to make sure that this sort of personalised care is available to everyone in secondary care. It's there in pockets. And I know it's there in to a greater extent than the 3 presentations we've had, but it won't be there right the way across London, and it makes sense on many levels, doesn't it? So there's a few reasons why we think it's important here on the slide. So bridging the gap between primary and secondary care, and we're all about integration and linking up now because we know that gives better care for the patients and the people we are on this earth to care for. Building and strengthening also the partnerships between the NHS, local authority and the voluntary sector and communities, really important. And I think that's become more important post-COVID, hasn't it? We need to understand what's going on in people's lives in order to support their better health. So if we can do that through personalised care roles, then we are in a better place. I think one of the things we need to be doing is doing it with communities, tailoring secondary care services to patient and community needs. So I think that engagement is massively important, and that's through the presentations this morning we've heard how that's happened and how valuable that is. Obviously, the non-clinical wider determinants of health have been repeatedly mentioned as something that we really need to understand in order to help improve health in our communities. I think education and awareness of services and the risk factors is something very obvious that this will do. I think I'm teaching, I assume, to the converted here, and all 134 of you, there have been more, but I think we need to spread the word and just how important this work is. And I think increasing the trust and patient experience improvements will be an outcome of this work. That right care, right time, right place. We've been saying that for a long time. I think it's making sure that we're using our resources, and they are dwindling resources in the NHS, it seems, doesn't it? Making sure that we're using the right resources at the right time of that patient pathway. And reducing health inequalities. We're all about population health, recognising where there are inequalities for individuals and communities and addressing those, and this has a really significant impact on that. And improving workforce retention by improving patient experience and outcomes is something that we are also very concerned about at the moment. So on the next slide is just some things that perhaps we will be asking you to do in order to make that a reality. We need that London-wide commitment, and I think in organising this today and talking with you, asking you to share your stories and having the panel session next week and unpick some of those issues that you've heard about and not quite sure. I think that's part of it. We would like to see a personalised healthcare lead in all acute community mental health and specialist trust to act as a point of contact. We need champions. We've got lots of them, you included, around London at the moment, but we need more and coming from all the different parts of the NHS. We need personalised care and MEC, making every contact counts, embedded in training and education for all clinical staff. We need the patient voice and lived experience to co-produce and share personalised care interventions, and that cross-sector collaboration and partnership, taking a systems approach, again, exactly what the NHS is doing at the moment, one of the priorities. More consistent funding and investment in personalised care. I'm afraid we haven't got any huge giveaways in cash at this point, but I think the argument is so compelling. I think we need to be thinking locally, system-wise and regionally, just how we enable that to happen, for that investment to be made, and clear guidance and policy and strategy for personalised care in secondary care, and the team will be providing that. So we've all got a part to play in that, in driving this forward. The next person you talk to after this meeting may be the key that unlocks something in your bit of London. As I say, we need to be looking at both at all levels, local, regional, and system level, to do that, and we need to be doing that at every opportunity we can. And a suggestion there is creating your own ambition statement for expanding personalised care provision in secondary care. I think, Molly, you're asking to share in Slido. Are we going to do that now, or move on to the panel, or we can do both at the same time probably? But this is a great session. It's absolutely the right thing to do, and I think now we have to do it, and we have to be creative in thinking about how we do it. Thanks.
Thanks, Jane. Yeah, so we do have the opportunity in Slido, so we've just popped the link in the chat for you to put in your own ambition statements around personalised care and secondary care. So please do share that in there. And thank you so much, Jane, for really brilliantly kind of sharing why it's everyone's business really to be thinking about combating health inequalities, and how we can do this more effectively together to really kind of achieve and achieve our ambitions in this space. So thank you so much. But whilst you're popping, just because I'm conscious of time and I know that people probably have burning questions for the panel, so whilst you are popping any questions or any ambition statements in Slido, I just want to take the time to introduce our amazing panellists. So we have Selina, Tara, Deb and Steve, who presented their projects, as well as Jane and Mel, and we also have Chris Strether, who is the Regional Medical Director for NHS England London, as well, joining us today on the panel. So this is just an opportunity for the next 20 minutes to ask any questions for the project presenters around their projects that they shared, but also to have a bit more of a broad discussion around personalised care and secondary care as well. So any wider questions or topics you want to discuss, please feel free to raise your hand and ask questions, or pop questions in the chat as well. Yeah, Jagan.
Hi everyone, thank you. Can you hear me?
Yeah, we can hear you.
Yeah, great, thank you. Just one of my questions be, what do you think the greatest challenge was to introducing personalised care roles into your services? I mean, because obviously it's quite new in some respects to secondary care. So just wanted to hear your view on that. Thanks.
Thanks, Jagan. Who would like to answer from the project presentations?
I can start if you'd like.
Sure. Yeah, go for it, Tara.
I think the fact that social prescribers are something that isn't entirely familiar within the secondary care team, and that it's an so far unregulated profession, makes it really difficult for HR to wrap their head around what a social prescriber is. And even coming down to like the DBS checks, we had a big discussion about whether or not someone was going to have patient contact and what kind of DBS checks they would need. So all of these things are so new that it really felt like we were inventing something rather than just introducing it. And then, of course, in addition to that, the fact that so much of the funding available for projects like this is 1 yearly. It really makes our ability to evidence outcomes, which are going to be, by nature of the outcomes, long-term, really quite challenging. So I find that I have now given the entire work of the project for patient care over to Remy and our social prescriber and the whole welfare team, and I'm just fundraising. So it's I think those are probably the two larger challenges.
Great, thanks, Tara. Yeah, Jane.
Just the first part of that about how you employ social prescribers. I mean, if one person has done it, we should be able to share with the rest. So I don't know whether there's some FAQs that could help, kickstart if those things are really causing barriers to doing this.
We certainly have shared our job descriptions for the adverts with all the other people who are working at BARTS and employing, and happy to do it for others.
That's great.
Great, thanks, Tara. Yeah, Joe.
Thanks, Molly. Thanks, everyone. It was absolutely fantastic webinar. So really happy. It's so amazing to see so many people on the call as well. So I guess my question was just around the impact these roles have had. How do you feel having these roles available has impacted on your ability to really care for your patients?
I'd prefer to answer that one. That's helpful. I mean, I think for us, the chronic pain patients are so complex that I think traditionally they would have just come and seen the GP, and the GP would have there would have been an expectation the GP can sort everything. And actually, I think having all these additional roles, we can't. And now I think working as part of the team with all these different personalised care roles, we understand we can't. And actually, I know my role as the GP, but I now understand what the social prescriber can do to help, what the health coach can do, what the pharmacist can do, what our secondary care colleagues can do. And I think the real thing is actually it's about using all the knowledges and skills and experiences that we have in the room more effectively, and recognising that actually the social prescribers have these incredible skills and fountain of knowledge that's much better than I have. I can do some things, they can do other things, and it's really giving everyone an equal footing to support these patients for all the stuff they need. So yes, they have medical needs, but they have all these other needs as well. So it's kind of recognising the different roles that everyone can play, and then supporting the patients with that. And they like that as well. The patients really like the fact they're cared for by a team that are all talking to each other and working together. So for me, it's just about recognising the skills that are in the room and making use of them.
If I can add to that.
Sorry. Yeah.
I think that there's been a knock-on effect in the rest of the team as well, for our safeguarding team and our ACPs and our the psychologists, starting to be able to address these social welfare needs that were something that we couldn't address before. As they tell me, I don't want to speak on their behalf, but they tell me has improved their day-to-day work as well, which is nice.
Great, thanks, Tara. That's really nice to hear as well, for sure. And great always, I think, to get that, ensure continually getting that kind of patient feedback. So we've got a few questions in the chat, but I'll first come to Mark, and then we'll go to some questions in the chat, and then I'll come back to other people with their hands up, if that's okay. But yeah, Mark. Thank you.
Hi, actually I did put my question in the chat as well. How can we make it easier to refer clients to social prescribing link workers for high intensity users? I appreciate that none of you are directly HIU. However, for me, as a non-clinician piloting this project in South West London, it's sometimes difficult to differentiate or identify a suitable referral. And I don't want to raise the expectations of the client by contacting them in the first instance and then being unable to support. I just wondered if the panel had any ideas about what may be an easier way forward. Thank you.
Thanks, Mark. Would anyone like to jump in on that?
I haven't got an answer. I haven't got an answer, but it's an issue that we need to address if it's difficult in practice. So I think we should have the wherewithal, shouldn't we, to make it as smooth and seamless as we can, using whether it's technology and all those great relationships. But other panelists have got their hands up now. They've had a chance to think.
Thank you.
Thanks, Jane. Yeah, Tara, I think you had your hand up.
So
first.
I think one of the things that we really need to all be asking for is a integrated directory of services where all of these things can quite easily be have referral pathways. And I think because everything's been so borough specific in the past and place specific in the past, it's really hard for a network like ours that spans 7 boroughs to really understand each of the different directory of services in each place. And so I think as a whole, those who are looking kind of strategically at it, Mark, your question is quite pertinent because it will address the needs that we have across the entire system in terms of more integration into the network.
Yeah, I mean, my concern is the fact that as a non-clinician, so I literally get sent a spreadsheet with name, date of birth, NHS number, and it may, or the number of attendances over the year, and then it may or may not have the reasons they had gone to the emergency department. And I think Google is a bit worn out now that I've had to try and Google as many medical codes as possible because all these acronyms, which I'm unfamiliar with, obviously. But perhaps in my experience, it is mental health issues and those that are still, active drug users or not sober, then obviously it's very difficult for me to engage at that point. And had I understood that client wasn't necessarily a relevant referral for me at this point and may need more specialist support, then it may make it easier for me to target those referrals that are more suitable for social prescribing. But I appreciate that it is an ongoing thing and something I just may have to bear with for a while. But thank you for your thoughts.
Thanks, Mark. Yeah, and Cal wants also helpfully put in the chat as well that around the use of digital case management systems supporting the referral pathway. So, for example, Joy, which has been commissioned for all PCNs in North West London. Mel, did you want to come in on that question?
Yeah, I was going to come in on that one. For us, as we got to understand the needs, that the social prescriber who worked with us, actually, she became like a single point of access, and she built relationships across NCL that would be a useful offer for our patients, but she would always have to do a bit of a triage conversation with them. So what was easy for us was we had one email, and then she took on the heavy lifting of mapping the individual's need to what was available across our ICS. But it was quite a shift for her compared to how she'd worked before, because previously she'd always worked with a Camden focus, but in sort of working and designing it together, that was just a really lovely resource to have access to.
Thanks, Mel. That's really helpful. Koji, I think you put a question in the chat and also have your hand up.
Thank you very much. As a link worker in the secondary mental health, it is really helpful. However, as I put the chat, not only me, we have still sometimes difficult time to back and forward with 2 systems to to smooth referrals between primary and secondary. And I'm just wondering, listening to the oral conversation presentation, other parts of London, social prescribing or this kind of personalized care, do people use one system or still kind of shifting between the different databases to understand how to follow the referral? That's my question.
Thanks, Koji. Tara, I know that you're looking into a lot of work around this. Did you want to come in on that?
I feel like I've been a real negative Nelly in this discussion. We've met quite a few challenges in digital integration, and you know, there is a platform that connects all of the primary care team, and secondary care is, at least in North East London, is having a really hard time getting into it. But it's definitely needed.
Oops. Sorry. I'm just having some issues with the slides. We'll go to Mark. You've got your hand up as well. Thank you.
Hi there. It's another Mark.
Oh, right,
just to keep everybody on their toes. And even worse, it's an interloper from the Shires. This has been really interesting. I've done a lot of work around personalisation, more out in community primary care. And I guess the question that just came up to me, when setting up these sorts of schemes, there's always a decision about, do you have your own social prescriber, or do you utilise the social prescribers within the primary care networks that were already there in the R's roles? And I was just wondering how you decided, and then how and if they interface, because there's a lot of potential shared governance and also information sharing, which we just touched on. So I guess, how did you decide to go internal rather than maybe partnering up with a PCN and then working up those referral pathways?
Thanks, Mark. That's a really great question. I think highlighting how there's so many different ways that you can approach it in secondary care. Is there anyone from the panel who has any comments on that?
We've done it sort of both ways. So in our pilot project, we were in a single practice, and it was just the social prescriber within that practice that was part of the team, essentially. The sites that we've done as part of the expansions, some of them don't have a social prescriber at all, so I haven't been able to do it, but a couple of them in particular are actually part of very large PCNs, and they've been using their PCN social prescribers as part of the project. I think both have worked really, really well, to be honest. I think it really depends on kind of the practice, the ethos, what you're trying to do. I suppose the advantage of kind of using a broader, the social prescriber who works across the PCNs, I think, is around this culture change. And I think that's what we're kind of all trying to do, and we're all talking about, is actually shifting the focus away from numbers very medical model to a much more personalised care model. And I think the advantage of involving PCN level pharmacists is that social prescribers, is that actually they become part of the team, they recognise this role, and that spreads across more practices. So actually it means that each practice they're working in understands their role a bit better. So I think if we're looking at kind of shifting the culture of healthcare, which is what we're really sort of trying to do this more personalised approach, I think kind of the higher level you can do that, the better, provided that team member is still part of the team, is supported, because I think that's something we've definitely seen, is that making sure these social prescribers are actually supported in their roles and have got a clinical contact and supervision and that sort of thing as they need it. So I think both works. That was just our sort of experience from what we've done.
Thanks, Selena. Yeah, and I think it's really specific depending on the needs of the exact project, isn't it? And what works well for that particular area, as there is so much kind of complexity within secondary care. So I think in some cases it would work really, really well involving PCN social prescribers, and in others it's kind of better to have someone based in the ward, for example. I'll come to Beth. You've got your hand up for a question as well.
Thanks, Molly. I just wondered from the patient's perspective, how the panel have found the patient response to the offer of support from these roles when based in secondary care.
Has anyone got any kind of comments from patient case studies or feedback from their projects?
We're really early days, so we don't have a ton of patient feedback yet. And as I said, the patient-facing side of things is really our social prescriber and ACPs. But what they've told me is that even though we're identifying 1/3 of patients in the heart population who are having social deprivation difficulties or challenges, not all of them actually want help. And I think it's important to be able to differentiate that before you start offering help. But beyond that, I think they're expressing a little bit of surprise that we're asking, and then gratefulness that we're trying to help.
The feedback we're getting from the people we're supporting to get out of the hospital is obviously very good. We're able to speed up for them. There's one case study that springs to mind. He was unable to get up the stairs, very limited mobility. We met people delivering his equipment at his property, and then we were able to support him longer term. So we do lead walks in the borough. So we're able to accompany him to the lead walks. Now he does them every day. I don't know, people will know Greenwich Park. He's been able to walk around that. And before he couldn't walk to the shop at the corner of his road. So we're able to get around people and help with the long-term support as well from our social prescribers in the practices. It does make a massive difference.
Thanks, Steve. Yeah, and I know that you had some examples of kind of patient case studies and feedback on your slide as well, which we didn't manage to cover, but we'll be sharing that in the slides, so thank you. I think we'll probably have time for a couple more questions. I'll come to Dan first, because I know that, Dan, you've popped something in the chat a while ago. Do you want to share your question? Are you there, Dan? Did you have a question? Okay, I think we'll Katie, can I come to you, and then maybe we'll come back to Dan?
Absolutely, thank you. So I think Jane's set out quite a lot of sort of options that we've got to sort of take forward the ambitions to embed sort of personalisation in secondary care going forwards. But I'd really value sort of thoughts and feedback from the panel about what you think we need to do to achieve that 2025 ambition, and who do we think needs to be involved to make it happen?
Thanks, Katie. Would anyone on the panel like to respond to that? Yeah, Chris.
So I'll say something because I haven't said anything yet, because quite a lot of the questions have been more appropriate for people who are actually doing it rather than people who sit in offices like me. I think I think there's a couple of things. There are so many people in the system that if we really embrace the opportunity that comes with this, could contribute and make a difference. But there's quite difficulty with all of us at the moment that everyone is so busy firefighting and doing what we've always done a bit harder because we've got a fed up workforce and not much resource. And I think there's probably a sort of leadership community job to say, actually just pause a little bit for breath and try and do some things like this which are different, which will have quite a quick return. Joe Fraser, who works with Jane on this in the London office, has presented some really exciting stuff on hypertension and picking out high risk populations and how you can make a real difference and get quite a rapid return on investment. So I think it's having the sort of almost the leadership nerve to sort of pause on the hamster wheel for a bit and try and do some stuff different. So I think events like this are useful, but we probably all need to go out and be ambassadors and champions for personalised care outside the meeting instead of all meeting, because when we're all meeting together like this, we all agree with each other anyway, don't we? So we probably need to go out and convert some of the sort of the less converted people, because it is a massive opportunity. And the final thing I think I may have missed it in the bits of the conversation I wasn't in, but I think there's also massive opportunity to engage communities in this, the sort of third sector and faith groups. We got really good stuff about vaccination during the COVID pandemic, but we probably haven't reaped the full benefit of working really closely with faith groups and community groups, and that's another way of us adding capacity to this and also spreading the word. Thanks.
Thanks, Chris. Yeah, no, really great points around, I guess, going out ourselves and really kind of championing this agenda among our different networks and continuing to do that following this meeting. Really, really important point, and definitely among kind of working better with the community as well, and particularly faith groups, I think, really important as well. So thank you. So we've got about 1 minute left. So if it's okay, I think we'll pull together any further questions. If you can pop them in the chat if you haven't managed to ask them, and then we'll pull together a bit of further questions and ask those to the panel offline, if that's okay. But just to summarise, so hopefully I'm still sharing my screen. Yeah. Yeah, so please do continue following this session just to share any ambition statements you have in Slido. We'll be pulling these out in the following weeks and sharing with the slides, the recording and themes from the discussion during the panel as well. Please also fill out a short feedback form. This will really help us to improve any future events that we run, and also help shape regional support to help expand personalised care roles in secondary care going forward. And then just to say, in response to just to come off what Chris said as well, around little things that you can do to kind of further this agenda, particularly around kind of championing and advocating in your local networks, but also if you're interested to join the Pan London community of practice, you can reach out to Beth or I at the email addresses there. But yeah, I'll be sharing the slides in the next couple of weeks as well. But yeah, thank you everyone. Hope it's been a useful session, and yeah, hope you have a good rest of your afternoon.
Thank you, Molly.
Thank you very much.
Yeah, thank you, everyone.
Thanks.
Thanks,
Bye-bye.
everyone. Super stuff. Thank you. Bye.
Thank you.